So, we're going to spend a little bit of time talking about a class of drugs called immune checkpoint inhibitors, which have really made a huge impact in human oncology. And it's one of the sort of the key therapies that's now really established immunotherapy as what people are referring to as that fourth pillar of cancer therapy for people, along with surgery, radiation therapy, and chemotherapy. And we're really, really excited that this is a class of drug that is starting to become a tool in our toolbox as well. And again, there's one drug that we'll discuss that actually does have conditional approval from the USDA that falls into this class. And then there are quite a few others that are currently being looked at. So there may be some other kids on the block coming up in the very near future. So the one that I'll tell you about here is Gilvetmab. And Gilvetmab, and as I mentioned, is conditionally licensed by the USDA for the treatment of both canine mast cell tumor and canine melanoma. And Gilvetmab is a monoclonal antibody that is actually sort of canine specific that targets a molecule called PD-1. And in mast cell tumors, a little bit more than 40% of dogs experienced an objective response, so their tumor shrunk up by at least half. And in melanoma, that percentage was about 20%. So again, in both of these tumor types, this established what's referred to as a reasonable expectation of effectiveness. And this, along with really, really good safety information, allowed the USDA to say, okay, we think that there's enough of a chance that this is going to be beneficial that we will give you conditional approval to actually turn this into a product that you can use for the treatment of your patients. So Gilvetmab is given as a 10 milligram per kilo IV infusion over 30 minutes, once every 2 weeks, for up to 10 treatments. And because one of the side effects that has been observed is an acute hypersensitivity reaction, an allergic like reaction, it's recommended to pre-treat everyone with Benadryl intramuscularly before the infusion. And then again, treatment can be continued in patients that are benefiting beyond 10 treatments. So some of the things that are really challenging, as I mentioned previously, is really trying to figure out how can we identify those patients that might benefit the most from this therapy. And one of the things that's been really tricky on the human side even is, depending on the disease process that's being studied, the biomarker that might help to guide whether or not the treatment is going to work is different. So there isn't one biomarker that seems to give us this kind of guidance for all the different human kinds of cancer where it's beneficial. So one of the things that's been looked at is tumor mutational burden. So the more DNA mutations a tumor has, the more foreign the protein looks to the immune system. And as a result, the easier it may be to generate an immune response. There may be certain kinds of signals in the tumor, more inflamed gene expression profile, expression of PD-L1 in the tumor, which you can assess using special stains. And in some cases, this is really crazy, the intestinal microbiome of the patient. So the bacteria that live in the guts of the patients may be an important determiner of response to some of these drugs as well. So this is something that we haven't even started to scratch the surface on yet in veterinary medicine, but I think is going to be a real key to the deployment of this therapy, is really trying to see if we can identify the biomarkers that are going to potentially help us know the patients that are most likely to respond. So stay tuned for a lot more about this in the coming years. The final concept that I just want to mention really quickly that I think we all need to keep in mind that's a little different with these immune checkpoint inhibitors is a concept called pseudoprogression, which is really interesting and really unique to immunotherapy. And that's the idea that in certain circumstances, a tumor might get bigger, not because there are more tumor cells in it, but actually because there are more immune cells in it. So what might look like a treatment that is failing could actually be a treatment that's gonna work if we just give it some more time. So again, in this sort of pre-treatment situation, you could envision that we've got a tumor with lots of tumor cells in there, but most of the really important immune effector cells are outside the tumor. And if we do something to the immune system that allows those cells to gain much more ready access to the tumor tissue, you could have what looks like a bigger tumor because it's now full of immune cells. And again, in humans, there are actually some very well set up criteria for knowing, all right, if I see a tumor grow, is that really tumor growth? When should I recheck to see if it's now shrinking or not? How much time should I give it? All those kinds of things are actually pretty well worked out in humans, and something that I think we need to keep in mind in our veterinary patients, although we don't have those same guidelines really well established to say, oh, here's when I'm going to check to see if the tumor's bigger. And if it is, here's when I'm going to check a second time to see if it could really be pseudoprogression or not. But here's just an example from the human literature to really demonstrate the way this can work. So this is what's called a spider plot. And what you're seeing here are different tumor volumes over time in patients after treatment with a checkpoint inhibitor. And again, in that dark blue line there on the bottom, you can see, yep, there are some patients whose tumors just shrink, period, end of story. But then there are these other patients you can see, like the light blue, that even darker blue, the green patient, where their tumors start to grow first, right? And then they start to shrink. And in human patients, this is measured in months. It's possible that the time course that we're going to need in our patients could be different. Overall, it does seem like maybe our dog tumors tend to grow a little bit more quickly than human tumors do often. So maybe the amount of time that we need to wait for a tumor to shrink or grow might be less. But again, just the concept of pseudoprogression, so that maybe not all tumor growth that we see is as a result of more tumor cells, and maybe it could be more immune cells. And if we wait a little longer, we might actually see a response, is a novel concept that's really foreign to a lot of us that we need to sort of keep in the back of our heads as we start to learn more about this class of agent and try to incorporate it into our arsenal. So again, we're just scratching the surface here. It's really exciting that we have this new tool in our toolbox, and we're really looking forward to learning a lot more about how to best use it, along with potentially some of the other therapies that you've heard about today.